Hi, good morning, everyone. Thank you to the organizing team for inviting me. It's been a great first day, and I'm looking forward to the rest of the conference. So, I've been tasked to talk about technical challenges of valve and valve TAVR. And as I was thinking about preparing for this talk, I was like, gee, it's been two decades, 20 years since Dr. Crebrier first performed the first in human case. And since then, TAVR has been streamlined to the point that structural operators today are very facile with not just TAVR, but also valve and valve TAVR. And we all understand that we need to predict the risk of coronary obstruction, assessing valve to coronary distance, looking for the risk of sinus sequestration, using basilica in some cases to mitigate that risk, thinking about patient prosthesis mismatch, using fracturing of the valve to optimize gradients and valve performance. And so instead of sort of belaboring those points, I thought I'd use a case-based approach to show some of the toughest cases I've had over the past year to see what some of these challenges might be. So this is a 64-year-old gentleman, and as you can see, multiple medical comorbidities. He has a history of aortic stenosis. He had a transcatheter aortic valve replacement 2 years ago. This was done with a 26 millimeter S3 valve. He also has severe PH, and he presented with significant shortness of breath, NYHA class 3 symptoms, and his echocardiogram suggested a mean gradient of 62 millimeters of mercury, acceleration time of 130 milliseconds. This is compatible with severe bioprosthetic aortic stenosis. Given that he had had a TAVR just 2 years ago, we performed a CTA to make sure this is not related to halt or ham, and it wasn't. And we thought that his valve degeneration was related to calcified leaflets of the bioprosthesis in a young patient with end-stage renal disease. Our surgeon felt that he was inoperative, and so we proceeded with a TAV and TAV. And so this is the baseline gradients before valve replacement with a mean gradient of 55 millimeters of mercury. And this is the valve. So we chose a self-expanding platform. It was relatively difficult to cross this valve. In fact, we tried after crossing to take the Medtronic valve platform bareback, and it just wouldn't navigate the valve. So this is a gentle predilation with an 18 millimeter true dilation balloon. And after that, it was a fairly uncomplicated case. We were happy with the depth of the implant. This is the aortogram. Coronaries are filling well. Everything looks good. The mean gradient was 0, and we were all giving each other high fives. The next day, his echo suggested, and we routinely get echoes the next day on our patients, and this suggested a peak velocity of 3.5, 3.6 meters per second, mean gradient of 28 millimeters of mercury, and an acceleration time of 120 milliseconds. This is very concerning day one after TAVR, and very different to the gradients that we got during the case. And I felt that given how calcified the leaflets were, given how difficult it was to cross the valve, that this was most likely related to some degree of recoil of the valve frame. And given that this was a self-expanding platform, we gave him some time to see if it would improve over time. And there was no change on his repeat echo in a month. So we brought him back to optimize his valve performance. This was the baseline gradients at that time. It was consistent with the gradients we got during the echo, a mean gradient of 28 millimeters of mercury. And we post-dilated this valve with a 24 millimeter true dilation balloon. There was an improvement in the gradients. It improved from 28 to 23. And I scratched my head and said, this is a guy who's fairly thin, small BMI, with a 29 millimeter self-expanding platform, and the gradients we have are out of proportion to what I would expect for a guy his size. We were already at 24 millimeters at the upper limit of the IFU for post-dilation of this valve. And so instead of going up a balloon size, I used the 24 millimeter true dilation balloon for a second post-dilation. And what I want you to focus here on is the central core wire, and you will see that there is a give right there. There's a give on the second post-dilation. And this was a scary moment during the end of the case, because this was either very, very good, that we had fully expanded the valve, or this was potentially very, very bad. But we did an aortogram. There was no pericardial effusion on echo. There was no annular rupture on the aortogram. The coronaries were filling. The mean gradient had improved to 12 millimeters of mercury. And you know, it's very early in TAV and TAV data and in the era of low-risk aortic valve replacement with TAVR. But here are my early thoughts, is that we are going to see more TAVR failures, particularly with TAVR now being approved for low-risk patients. And when we are treating these patients, understanding the mechanism of valve failure is probably the most important thing in trying to address the underlying mechanism in treating these patients. And a couple of these cases have now made me wonder whether we should be aggressive about routine pre and perhaps post dilation in these patients with severe bioprosthetic valve stenosis to optimize these gradients on the day of the procedure. So moving on, this is the second case. This is a 77-year-old gentleman. He has a history of aortic valve replacement. This was performed with a surgical aortic valve replacement of the 25 millimeter trifecta valve. This was performed in 2010, so 12 years. At my center, the surgeon back then was very aggressive, and this was his valve of choice for using trifecta. And I'm glad that it's off the market. We are now seeing so much of this trifecta failure and are some of the toughest valve-in-valve cases I think we do. He, in fact, outlived the average or median life expectancy or valve performance expectancy for trifecta, which is about 6 years now. So he actually survived that to about 12 years. But he presented with significant shortness of breath, near rest symptoms. He was bloated like a balloon. He got diuresis negative 40 liters. His echocardiogram suggested an EF of 20%, severe transvalvular aortic regurgitation, and this was his echocardiogram. Severe AI, pressure half time of 230 milliseconds. And so in planning of the valve-in-valve TAVR, this was a CTA. His left main to coronary distance was 5 millimeters, so I'm happy with that. His RC was non-dominant, so that VTC of 3 on the right didn't bother me so much. As you remember, he had had CABG at the time of AVR, but both his vein grafts to the left system were occluded. This was the STJ. There was no concern about the risk for sinus sequestration with valve-in-valve TAVR. And so this is what we did. He had, to Dr. Carr's point, he had a large annulus. He had a history of coronary artery disease, and he was a very thin guy. And so as a result of that, we chose a balloon expandable over a self-expanding platform. And so we took a 26 millimeter S3. We aligned the top of that valve to the top of the posts, a very slow dilation up front until it sticks, and then give it all. And after that, we obtained gradients with a mean gradient of 18 millimeters of mercury. And what we know from the VIVID registry is that a higher mean gradient in patients with valve-in-valve portends increased risk of mortality down the road. And so it is likely that his mean gradient at 18 during the procedure was going to be higher on the echo the next day, and we decided that we want to optimize this. Now, trifecta, as you all know, is a non-frackable valve, but it can be remodeled, and it has externally mounted leaflets. But we took a 25 millimeter true dilation balloon with a coronary deflator on the side and gave it all. And this was improvement in the mean gradient from 18 to 11 millimeters of mercury. Following this, he developed severe hypotension. His MAP started dropping from 60 to 40 to 30. And the biggest concern I had at that point was whether he's had annular rupture because of the fracking or remodeling of the valve. But that was not the case. The aortogram revealed no dissection, no annular rupture, and the coronaries were filling. And this is an important point. I'll come back to this at one point in the next slide. But his coronaries on the aortogram were filling. His echo suggested no pericardial effusion, and shortly after that he VF'd. So he was shocked, started CPR, put in an impeller to restore the hemodynamics. And at this point we started, once we had stabilized him, started to scratch our heads as to what might be going on. And even though the coronaries were filling on the aortogram, with the VF, the biggest concern was whether he's had coronary obstruction. So selective coronary angiography revealed, as you can see, a distal embolic left main occlusion. This was not present on his prior angiogram. And we also performed IVUS for a couple reasons. One is not just for optimizing the PCI, but also to look and see whether we need to extend this stent all the way back to a snorkel. Has there been, even though the CT didn't suggest increased risk for coronary obstruction or sinus sequestration, has that been the case with the fact that we had to remodel the valve? But that wasn't the case. There was ample of space here, as you can see on IVUS. We did a crossover stenting from the mid shaft of the left main into the LAD. And he did fine. The impeller came out the next day. He went home. He continues to do well. But, at some point, perfection is the enemy of good. And I've always wondered whether, in trying to optimize gradients for valve and valve TAVR, we trade the risk for potential and life-threatening complications. And this is from the VIVID registry, where the risk for coronary obstruction is highest in those patients with externally mounted leaflets. And what this case has left me with is that, yes, we try to optimize gradients. Yes, we try to frac valves to get the best gradients and valve performance. But should we be less aggressive in patients with externally mounted leaflets and trifecta valves, which I'm glad is off the market now. Thank you.
I actually want to ask you a question. Why did you decide to use a balloon expandable valve in the second case?
Yeah, so his BMI, he was a very thin guy. His BMI was less than 20. He had a large annulus. It was going to be a 26 millimeter valve, and he had coronary artery disease. So we debated between going with a self-expanding versus a balloon expandable, but thought that we'd get reasonable gradients with the balloon expandable.
23, right?
26. It was a 25 trifecta.
25. So Alan, I mean, you're a big
Actually, you're
guy. I'm saying that would you consider, I mean, I know you don't like self-expanding valves that much. Or would you in this consider putting a self-expanding valve? Especially in trifecta where it's difficult to, you can't break the annulus.
Yeah, well, actually, no, I think I would consider using a balloon expandable again.
Anyway.
Yeah, anyway. It's...
Alan, you're
it's not my philosophy, it's just a question.
Just joking.
It seems logical, not to use tall frame valves, in this situation, especially in this patient. Okay, he was 80, yeah.
He was 77, yeah.
7, yeah. But now we'll have valve failure in younger patients,
Yep.
and so we'll have more and more valve failure that we'll have to treat with valve-in-valve. And so I think that using a balloon expandable at least make easier the reaccess of the coronary artery, which is so important, So,
Yes.
Yeah. Well, I was thinking,
So I would do differently.
Yeah.
If I had, even for me, this patient for sure, I would do leaflet modification. I would, because now you don't use, I wouldn't use basilica like a device like Shortcut,
Yeah.
which is a very nice device where you can easily cut the left coronary cusp. First of all, it would have prevented you from having this embolization.
Yeah.
Second is that as you mentioned, that if you do a leaflet modification the first time, and now you put a valve inside, if you have to go with, in this patient, there's a very high likelihood he's going to have a third valve, correct? I mean, he's not going to last more than 5-6 years.
Well, he was 77 with an EF of 20%.
Yeah, I'm saying I don't know, but if it does,
Yeah.
then because you cut the first time the
Yeah,
leaflets,
yeah, you have
it's
the
okay,
ability to
you
do it.
can do the same thing the second time.
So that's an interesting point. So with a VTC of 5, with a low risk for sinus sequestration, would you still do for the possibility of a valve-in-valve?
Yeah, but you still had a coronary
Yeah.
problem, right? In spite of VTC being 5.
Yeah.
Now, if you cut the leaflets in the beginning, you would not have had this problem.
Do you think embolic occlusion could be predicted in patients with externally mounted leaflets, or was this a fluke chance?
I mean, the only few cases I've had coronary obstruction have been always these star cases.
Yeah.
When I balloon dilated, post dilated, and then I've been coronary scar.
Yeah.
I mean, I find it very difficult. When I get very nervous.
Yeah.
Without coronary obstruction, without externally mounted valves are bad valves.
Yeah, I agree.
I just would like to have a technical question for you. If you do a valve rupture, how do you select the balloon size for rupturing the surgical valve?
The app I use is the app by Vinny Bapat, which is the Valve-in-Valve app, that gives you the internal diameter, which is usually 1 or 2 smaller than the size of the valve, and then I also use the CT to see what the average and the minimum and the maximum diameter of the inner diameter of the valve is, and between the two decide which size do we go in with.
Okay. Yes, actually, I have a question because, recently we had a workshop in my center with live cases coming from abroad, and there was a center in the United States, I don't say the name, but they were doing valve rupture. And the size of the valve was 23 millimeter. And the operator said that in this case, they should use a 26 millimeter balloon for rupturing the valve. It's a big center in the United States, so it's not a small. and the rupture of the annulus at the same time, So I told him on the screen, I said, why are you using such a big balloon, in a small valve? It's because the pressure is less, we can rupture more easily and so on. And we could observe on the screen that the valve was really ruptured. We could see the rupture on the screen, but we also had the rupture of the annulus. So, the people who are doing valve rupture, they should be very careful, not to oversize the balloon when, to do this rupture, which is a good thing.
Particularly using a coronary deflator at the end as well to increase that pressure. In fact, this question has also been looked at the Vivid registry for fracking of valves, and what was found was, on average, you need to increase the size by about 2 millimeters to be able to achieve a frac. And I think the newer generation Savo valves have become a little more facile with us seeing the frame that can be, you can see the frame being fractured, and that's going to be helpful down the road.
The other thing is when I do valve in externally mounted valves, I always protect the coronaries.
Do you?
Even if there's say BTCs, because I don't know, and I never, especially when you have to do a post dilatation.
More generally speaking, I think we can say concern that the surgeons today should avoid using trifecta and mitral flow valves, because most of the problems that we have in the valve-in-valve cases are coming from a surgical valve,
100%.
And
yes.
so now I think the surgeons have accepted,
Yes.
and also they can also enlarge the aortic annulus before setting the valve inside, and this is good for the future because we have to think in 2030, what will be the situation. Well,
in fact,
thank you.
in US, trifecta has been taken off the market for that reason.
I have a question. In your first case, you found, the initial true balloon which you took was 18, and then you upgraded to 24. So, were there any aortic rupture was definitely an impending risk. So, were there any special precautions which you took to tide over the situation?
These cases are hard to predict, and I think we have to go in all sort of plan for all cases. What we plan in general is to get these patients immediately on ECMO and to tap in effusion and then have the surgeon bail out. And for patients that are non-surgical bailouts, then we don't put them on ECMO because that's the definitive treatment is going to be surgery, and if we can't offer that surgery, then we don't put them on